So January 2017, the patient presents to her oncologist with again more symptoms of weight loss, nausea, and fatigue. And so she gets referred back for another CT scan, which showed even further progression in the lungs, a little progression in the liver. And now the patient has a couple of bony lesions that are non-threatening. So the patient essentially shows evidence of progressive disease, and her CA level are rising significantly. So the patient, after discussion with her oncologist, expresses motivation to continue with therapy. Her performance status is 1. She's still doing great. She's still doing her house chores. I mean, she's a little bit more fatigued, limited, but overall still very functional, and she wants to continue on further therapy. There are no clinical trials that she would be eligible for. The discussion went between herself and her medical oncologist regarding the 2 oral agents that are available for refractory disease, regorafenib and TAS-102, and the decision was to proceed with regorafenib. So now the patient progressed through FOLFIRI-cetuximab, CAPOX bevacizumab, 2 lines of therapy. Now the question is, what do you do next? So what would be done next is essentially, a couple of options that are now made available to us. Again, as a reminder, this patient is microsatellite stable, so immune therapy outside clinical trials is not an option for this patient. So our 2 options are TAS-102 and regorafenib. There are differences between the 2. TAS-102 is your traditional cytotoxic agent that essentially is a fluoropyrimidine or part of that fluoropyrimidine superfamily. It's not 5-FU, it's not capecitabine. It actually has functions within it that will allow it to work when 5-FU and capecitabine fail. And so in that sense, it's a little different, although it belongs to that superfamily, but it's a cytotoxic agent. Regorafenib, on the other hand, is what we call a multi-kinase inhibitor. Has multiple targets. It's not your traditional cytotoxic agent, it's a targeted agent. Has a lot of targets on the cancer cells and in the environment, including VEGF. So this agent essentially is what we call a dirty drug, promiscuous, essentially with all these targets. So they're different. And these agents have never been compared head to head. They each one of these agents had 2 large phase 3 studies. And with regorafenib, in addition, had an observational study called CONSIGN. So we have CONCUR, we have CORRECT. We have CONCUR. CORRECT is the larger study that essentially led to the approval of the regorafenib. CONCUR is an Asia-only study, and CONSIGN is essentially the observational study, which collected, I think, more than 2,000 patients. On the other hand, we have TAS-102, which essentially has the RECOURSE study, which was the large study that led to its approval versus placebo. So similar design than the CORRECT. Then TERRA, which is very similar to CONCUR, meaning that again it was the drug versus placebo, and was in Asia only, similar to CONCUR. So we have these studies on hand that are similar, but like I said, we don't have any comparative data looking at TAS-102 versus regorafenib to help us with the decision. So we really have to rely on historical controls, personal experience, and there are other factors as well. When we look at regorafenib, between CORRECT and CONCUR, CONCUR had patients who were less pre-exposed to treatment. And in other words, in Asia and certain Asian countries where there is less availability of VEGF and EGFR inhibitors, those patients will get regorafenib a little earlier on. Historically, when we looked at CORRECT and CONCUR, it does seem that regorafenib may have a further benefit if moved up the line. When we look at TAS-102, we have, as I said, RECOURSE and TERRA. And when we look at very similar populations again, with RECOURSE, patients had to fail all standard therapies, similar to CORRECT. And in fact, with the TAS-102 study, the RECOURSE, about 20% of the patients had prior regorafenib. And prior regorafenib did not seem to affect the benefit that you see with TAS-102. So whether you had rego or not, you still derive benefit, which is good news. At least we have that little hint there. TERRA, on the other hand, is a study that is like CONCUR, had less pre-exposed patients. Interestingly, that TAS 102, as it moves up the line, didn't seem to have a larger delta, meaning the benefit is maintained regardless of where you place it in the line of therapy. That may be, one of our hints that perhaps in terms of sequencing, regorafenib, then TAS 102 for most patients, but there are some patients where performance status is borderline, PA, close to PS2, or the liver is quite dysfunctional, not too dysfunctional, of course, because you can't give either drug, but dysfunctional enough to worry about regorafenib, would give TAS 102 first. On the other hand, a patient who clearly has issues with their bone marrow, you want to avoid TAS 102. Their toxicity profiles are different. And then Consign just confirms a lot of the observations with Concur and Correct.